Everyone had a good Thanksgiving.
Hit it, girl.
That one on the right.
That's
Okay.
definitely
Get your eyes set.
Yeah. Yes, Mom.
Hit it, girl.
But Robbie, when I get a job, I hope you scream that at me.
Oh, yes.
I think we are now recording. So we're ready to start. So tell me when your eyes are in. Some people still focusing. Okay. Looks like everyone's good there, so let's start. Should we start there? Jessica, do you want to start?
Sure. Okay, so looking at the top, the corneum looks slightly orthokeratotic, and the epidermis looks pretty normal. Below in the dermis, you see definitely a cell population that, if we zoom in closer, we can get a better idea as to which type of cells. But
and we absolutely can zoom in closer and look at them. To me, though, the easiest way to make the diagnosis is to go out farther.
Okay, so if we go down into the dermis, looking around vessels, you can see infiltration of cells as well that look slightly fibroblastic.
So there's some evidence of vessel damage here with a little red cell extravasation.
Mm-hmm.
The cells here, are they black like these lymphocytes, or are they gray?
They're more gray.
So they're gray, and are they overlapping one across the other like those lymphocytes, or are they polka dot, evenly spaced?
They are evenly spaced out.
So what would be a superficial dermal infiltrate that is sheet-like but polka dot remain discrete and gray like this?
That would be mastocytosis.
That would be a mastocytoma. And it's a scan diagnosis at 2x. When you go higher, you tend just to confuse yourself. That's, usually this is about the best power to make the diagnosis, where you just have that polka dot, diffuse pattern. They don't overlap. Everyone's discrete. They're gray. They're not black. That's a really good mastocytosis. And it's nicely done. Okay, that one is more like a fellow case. So
We see.
a corneum, and is that a normal corneum?
What do you say?
Is that a normal stratum corneum?
It doesn't look normal.
Does not look normal, right? It's a massive corneum. And if you were looking at it, about how thick would it be?
Do you need a measurement or?
I mean, that's like a 6 millimeter punch, maybe, or at least a 5 millimeter punch, and I don't think that's the whole thing. So, that's probably about like that for the stratum corneum. If this is all over the patient's skin, if this is the entire skin surface, yeah, and which one would be that thick?
Hystrix?
Or so thick that it fissures into plates?
Just like the cold.
Sometimes you'll see lipid collections or Odlin bodies on if you do ultramicroscopy, but just the thickness itself, it's Harlequin fetus. There's not much else that's going to be this thick all over the body. I mean, it's beyond what any other ichthyosis does. Okay, so David, how about this one?
Corneum's a little compact.
Yeah, the corneum's a little compact. So is your epidermis particularly thick, or is it just that your corneum's compact?
Looks like more the corneum's just compact.
Yeah, your epidermis is pretty normal. So ichthyoses fall into two types, hyperproliferative and retention. So this is more likely retention. So retention ichthyoses that have no proliferation. What are your major ones?
I know Ichthyosis vulgaris.
Ichthyosis vulgaris. Judging by the granular layer, is this Ichthyosis vulgaris?
I think, well, there's still a little slight one. It could be.
So how many layers thick is your granular?
Okay, it's like 4 or 5 there, so probably not Ichthyosis vulgaris.
So probably not Ichthyosis vulgaris.
So
In
maybe-
IV, you're lucky if there's one, because that's the defect, right?
Lamellar? Is lamellar Ichthyosis? Yeah.
So, but lamellar is hyperproliferative, so lamellar has acanthosis as well.
The other retention.
So the other major one that's just retention, it's a guy, and he was born of a C-section, and he
yeah,
looks really bad in the
steroid.
winter and not so bad in the summer.
Excellent.
So that would be X-linked, correct. So X-linked ichthyosis, the steroid sulfatase or aryl sulfatase C, it's the enzyme that induces labor, so they're usually were a C-section birth, and it's distinctly worse in the winter than in the summer. And it's a retention hyperkeratosis, but it retains a granular layer.
And so we're seeing some acantholysis.
There's acantholysis.
I'm trying. Yeah, there's some dyskeratotic
And
keratinosis.
dyskeratosis. So if you have acantholysis and dyskeratosis with formation of corons,
Mhm.
what kind of things are in that category?
So like Darius.
So like Darius, could this be Haley-Haley?
You do not classically see the corons in Haley.
And what color are the rings around the nuclei in Haley-Haley?
Pink or
Yep, red and are only red. What color are they in this case?
it's more of like a deep magenta.
So they are blue in this case. So Darius can do blue, clear, or red. Haley-Haley is only capable of doing red. Haley-Haley tends to be full thickness, dilapidated brick wall acantholysis. The Darius group tends to split suprabasilar with clefting and villi formation sometimes. So this could be Darius. If it's all over the body, it could just be Grover's.
Exactly.
What about epidermal ichthyosis?
I'm sorry?
It doesn't have like that
This-
scoop line.
okay.
Oh, epidermolytic ichthyosis has, instead of having acantholysis and corons, it has a thickened granular layer where the granules are abnormally both blue and red, and there are vacuoles all through the granular layer.
So, relatively normal looking skin. There's increased pigment, probably because the patient is of Fitzpatrick 4 or 5. And then there's this hyalinized, like pink layer underneath the epidermis.
Yep. So if you look at your epidermis, is your epidermis abnormally thick?
It's a little thin, but I don't know if that's the age of the patient.
Yeah, so, it's probably just normal. It's certainly not thick. If anything, it's a little thin. is it normal for the stratum corneum to be thicker than your
It's not. You have some retention of the stratum
epidermis? So
corneum.
you have some retention of a compact corneum, and then
You have a very thin granular layer as well.
and a very thin granular layer. So this one is
Ichthyosis vulgaris.
Ichthyosis vulgaris. So normal epidermis, thick compact corneum, accentuated granular layer, X-linked, attenuated granular layer, Ichthyosis vulgaris. Okay, epidermis normal or acanthotic?
It's acanthotic.
So this one, is this purely a retention hyperkeratosis, or is this one proliferative?
This looks like both, or more
So
proliferative.
Yeah, proliferative, and you certainly have a thick corneum, but it's not purely retention. So it looks different from X-linked and vulgaris, where your epidermis was normal. This one, your epidermis is thickened, and so is your corneum. And your granular layer is
Looks-
about normal, right? Maybe just a little bit thick. So what
Just-
might you think?
Maybe like lamellar.
Yeah, so this is like what you'd expect in lamellar ichthyosis. So ichthyosis vulgaris, thin epidermis, compact red stratum corneum, attenuated granular, X-linked ichthyosis, normal epidermis, compact red corneum, accentuated granular, lamellar, acanthosis, hyperkeratosis, maybe a little bit beaded, thickened granular, and then Harlequin fetus is like an accentuation of this, where your corneum just gets many times that thick.
So it looks like there's some pretty prominent acantholysis.
So prominent acantholysis.
Looks like it's some
What color are the rings around the nuclei?
red.
Any other colors? Or only red?
Pretty much only red that I see.
Pretty much only red.
So,
So there's acanthosis, acantholysis, red rings around the nuclei.
Haley.
Looks like Haley. Who described it first, Haley or Haley?
This is the dad.
I think it's the latter.
The latter. They were brothers or father and son. It was one report. There was no scandal. Haley didn't steal it from Haley. Okay.
Looks like a dermal infiltrate. Looks
Like a
pretty
dermal
polka dot.
infiltrate, and it's kind of polka dot pattern. They're all evenly spaced.
So mast cells.
Yeah, so mast cells. Mastocytoma. And again, it's a scan diagnosis.
I'm not going to get more than that. I just can't go up.
You go too high, it gets harder, not easier.
So you have some hyperkeratosis there, and hard to tell. Definitely a process going on in the epidermis. I don't know if that's acantholysis or.
So, what part of the epidermis is abnormal?
Just at the granular layer and the spine.
So it's kind of the granular layer that's abnormal. And in a normal granular layer, what color are the granules?
Dark blue
Blue. And here some of them are blue and some of them are
or red.
red. That's not normal. And why is the granular layer all shot full of holes?
It's not happy.
As
It's
if
just,
the epidermo was lytic.
So like
Right.
epidermolytic ichthyosis.
So an epidermolytic ichthyosis. So epidermolytic hyperkeratosis or epidermolytic ichthyosis, you have a compact corneum. You have a thickened granular. The thickened granular is all shot full of holes. The granules are bizarre shapes and sizes and vary in shapes and size. Are any of us watching on the line? No. Okay, so we can just keep going. And the epidermis is shot full of holes, and the granules are variably pink and blue.
Okay, so it looks acanthotic, as well as there's a lot of hyperkeratosis.
So there's a lot of hyperkeratosis, and is the corneum uniform?
No.
So it's not uniform, and is the epidermis intact everywhere?
No, not everywhere.
And so there are areas where you have dyskeratosis forming a red V in the epidermis, and then does the abnormal corneum come straight up from that, or is it at an
No, it's
angle?
kind of at an angle.
So it suggests that rather than being static, this is something that's migrating outward, right? Leaving like a trail of smoke,
Like a porokeratosis.
like a porokeratosis. And so various poros are inherited, some are acquired, but that's the pattern of a cornoid lamella. Let's see.
How do you distinguish that from Vergus IP with the dyskeratotic cells? That's not that specific.
Doesn't form a V.
Maybe more across the whole.
Yep, correct. So they're scattered. The one that's probably maybe impossible to tell apart is verrucous stage of incontinentia pigmenti versus Still's disease, where they have all the dyskeratotic cells in the epidermis. Okay. If you're thinking normal, don't panic. It's good to have a normal
Not jumping out at me.
skin differential. So if you go to the back of your book, there's a normal skin differential, which you can go through. The only thing that I'd say is it's maybe the dermis is a little busier up here than it is down there,
Yeah,
a little more cellular.
Perivascular.
Yeah, maybe something perivascular. So then the question is, what is there that's perivascular?
Could they be mast cells?
Well, they're certainly gray rather than black, the nuclei. And if we get ourselves into focus here, you can see distinctly granular,
Yes.
right? So I would say they are probably mast cells. So what would be a subtle perivascular mastocytosis?
Should be TMAP.
TMAP,
Don't ask me what it
telangiectasia.
stands for.
That's why we have the acronyms. Telangiectasia macularis eruptiva perstans. So why does derm have all these bizarre Latin names? Because we're a small specialty, and small specialties have to be able to speak internationally. So whether you're Italian or Greek or German or American, the name is telangiectasia eruptiva perstans.
I thought you were going to say this because you're overcompensating because you're small.
We're overcompensating. Small specialty, big names. I don't know. Maybe there's an element of that, but we stick with the Latin because it's international. Then it's all everyone uses the same names across the world. So, and it's a dead language, so no one, it's not favoritism towards any living language.
The language bias is real.
Don't say Latin instead. I was a classics major.
Oh, sorry. Well, it is a dead language. It doesn't mean it's not a useful language.
I would argue that.
So there's definitely dyskeratosis and some acantholysis.
So, dyskeratosis, acantholysis,
acantholysis.
Dariés, and this has very distinct villi, so suprabasilar acantholysis, and finger-like villi, corons, which can have red, clear, or blue rings around the nucleus. And sometimes higher up you will see grains, which are a flattened blue dyskeratotic cell. Let's see what else we have here. There's some new territory here.
So this looks like PXE.
So it looks like PXE. You have dystrophic calcified fibers all broken up in the epidermis. It's not collagen, it's the elastic fibers. But what if this person doesn't have tears in Bruch's membrane? So there are no angioid streaks, there are no other stigmata, no vascular, and it's a 60-year-old black woman who's had lots of kids.
This could be the periumbilical, there's a name for it, calcified elastic fibers.
Yeah, so that's basically it. So perforating calcific elastosis is one name for it, or periumbilical PXE it was called, but it's not really PXE at all. It's calcified stria. So it's usually the classic description is a multiparous black female. So usually the ones I've seen are usually 50s, 60s, and they're getting what looks like a perforating disorder, but they don't have renal disease, and it's in the stria. And on biopsy it looks just like PXE, and the important thing is just to recognize it because they don't have any of the other inherited issues that true PXE has. The other thing that can look similar is if you work for the highway department, they use salt.
In this room, does anyone? For the
People moonlight. So if you work for the highway department, they use salt on the roads. But if you're doing your own driveway and you don't want to kill the grass, you use calcium salts. Ice melt is the common brand name. If you get salt on your skin, it's harmless. If you get ice melt on your skin and then the skin gets wet, you get some pretty nasty third-degree burns that histologically look just like PXE.
Interesting. Sounds like a factitious disorder ready to go.
Yeah.
Okay. Okay.
So you kind of have a cup-shaped invagination, and it's got that EHK type of look.
So you have epidermolytic hyperkeratosis, but it is a solitary cup-shaped lesion.
It'd
So
be
this
an
is
epidermolytic acanthoma.
an epidermolytic acanthoma, solitary. If you looked for keratin 1 in 10 mutations here, would you find them?
No.
Actually, you do. So it's just like a solitary neurofibroma. Has the same neurofibroma
Gotcha.
mutations as von Rex. It's not germline. It's just a single sporadic. In an epidermolytic acanthoma, it's the same mutation. It's just focal, sporadic, postzygotic mutation that's not germline. But in this patient, this was a linear lesion on the flank, thought to be a linear epidermal nevus, which is a total lie because that's obviously volar skin. But bear with me. You know, what if the scenario was this was a linear lesion on the flank? Linear epidermal nevus-like lesion. What would the significance be?
Germline, possibly germline.
So could be germline if it where loss of heterozygosity, or more likely a postzygotic somatic mutation, but mosaicism. And then if it involves your abdomen, what may it also involve?
Eggs or
Gonads, gonadal tissue, right? Because gonads do not originate in perineum, or pelvis, they originate in the abdomen and migrate, right? So abdominal segments. So what can happen is you have a mom who has a linear streak on her abdomen, and child is born with epidermolytic ichthyosis involving the entire body because it's autosomal dominant, and she is mosaic, including gonadal mosaicism. What if she has one linear streak and it's on the neck? What's the risk of gonadal mosaicism?
Feels low.
Really, really low because the gonads don't originate in your neck, right? That would be a long migration, right? So they originate in the abdomen. But what if you have one on your neck and one on your left leg?
It's kind of a DMZ situation there.
The only way that can happen is if the postzygotic mutation occurred before gastrulation. So gastrulation is where you get a coelomic cavity, a cavity forming within the embryo, like a coelomic.
I thought you were saying like salami.
Well, it's an Italian concept.
They're all.
So gastrulation is where a cavity forms in the embryo. Post-gastrulation, every cell is dedicated to become something, an arm, a leg, a something. Pre-gastrulation, every cell contributes everywhere in the body. So damage to a fetus after gastrulation, you're going to miss eyes, legs, arms, because every one of those cells was dedicated to become a part of you. Prior to gastrulation, you can take off cells, clone things, and everyone is a complete whole individual. So gastrulation is where that organism defines itself, that populations of cells are going to give rise to different things. If you have one cell that takes a genetic hit, and yet you end up with a streak on your neck and a streak on your leg, that could only have happened prior to gastrulation, right? And prior to gastrulation, those cells are disseminating to everywhere in your body, which includes then gonadal tissue. Right? So that's much higher risk. So isolated streak on the abdomen, risk.
Do you know what
Isolated streak on the neck, much lower risk. It's probably around 2%. Which unfortunately for the baby is all or none. Right? And then widely separated streaks can only occur from postzygotic mutation prior to gastrulation or loss of heterozygosity. If it's loss of heterozygosity, your risk is 50-50 for every child. If it is postzygotic somatic mutation, it's probably around 2%. Okay. Jessica, what do you see here?
So again, I see pretty busy dermis with the normal appearing epidermis and the top orthokeratosis.
And are the cells spindled or round?
In this part, they appear round.
And do they overlap or are they polka dot?
They appear to be spread out or giving each other space.
So what do you think?
So this looks like it would be another mastocytosis.
Another mastocytoma. Very good.
So there's some dead reds.
There are dead reds, and are they forming isolated V's or are they scattered? I want to make sure we're still going to focus on line.
Something scattered.
Oops, we're a little off.
There a little bit of spongiosis as well.
So there's a little spongiosis, and there's one clump of them, or whorl, and then they're scattered elsewhere, but they're definitely a whirling phenomenon here. So what do you think this could be?
Could be stills?
So it absolutely could be Still's disease if it were, either adult or child. But one of the hints is, do Stills get EOs? So this has EOs plus that pattern. So what looks like Stills has EOs, incontinentia pigmenti, correct. So incontinentia pigmenti is it your whole body that's involved?
No, it's sort of a Blaschkoid.
Blaschkoid linear streaks. And those Blaschkoid linear streaks, is it usually one isolated, or are they all over your body?
Usually over.
Yeah, you have multiple of them. So we talked about isolated streaks, we talked about two widely separated streaks. Now this is someone who's streaky all over. And the cells here, are they living exceptionally long, or are they dying exceptionally early? These dead reds. They're dying exceptionally early. So when you look at the streaks, they are not the normal width of a Blaschko segment. They're skinny, skinny streaks because they're streaks of a lethal gene that kills cells early. So if you were born with a lethal gene and you're male, what happens to you?
You don't make it.
You don't make it. And if you're born with a lethal gene but it's X-linked, and through lionization it's only expressed in half of the segments of your body, then you're a female with skinny segments all over, right? Which is what things like IP and GOLTS look like. And they are all lethal gene. So you get, if that streak, if you're unlucky and one of those skinny streaks goes through where your eye would have been, you have microphthalmia or you have no eye at all. If it goes through your jaw, you have no teeth. If it goes through your hand, you have no fingers. It's lethal to whatever segment it happened to hit by luck. Same kind of thing in GOLTS. So all of those lethal genes, they have multiple skinny Blaschkoid segments, and you lose tissue. So you have absent atrophic tissue. Whereas tumor suppressor genes, instead of looking like skinny Blaschko segments or even normal Blaschko segments, they are plaque-like lesions because it's a tumor suppressor knockout. So they push everything out of the way. That's like the forehead plaque of tuberous sclerosis, segmental neurofibromatosis, big plaques because it's a tumor suppressor gene that's been knocked out. It's growing beyond its bounds and pushing everything out of the way. Whereas here you have a lethal gene that's killing cells, so it's going to be a skinny Blaschko segment. So a lot of this is clinical pathologic correlation, but here you have a picture that could be Stills at scan in an adult, and the whorls you get in the corneum look exactly the same in IP and Stills. IP gets pigment incontinence and gets eosinophils. Stills does not. And then there's the fact that it's a little girl missing an eye and missing fingers and lots of streaks of these lesions that make it diagnostic.
The epidermis is kind of degenerated. There's some repair. So I don't see a lot of dyskeratosis, and it could be epidermolytic hyperkeratosis.
So in epidermolytic hyperkeratosis, you'd have a big, thick granular, and your granules would be both red and blue. Here I only see blue. Is that a normal cell?
No, so that's...
What's wrong with that cell?
Looks like it's dying.
So
just dyskeratosis.
So there is dyskeratosis, and that particular cell is round. All of these dyskeratotic cells are flat.
Some grains.
So you've got grains, you've got corons, you've got, this is actually all corons and grains. So, what?
So it could be Grover's focal.
Yeah, it's focal, it could be Grover's, but it could be Darier's. That particular biopsy was from a patient with Darier's.
Ochronosis.
Ochronosis. And ochronosis comes from what genetic defect when it's inherited?
Is it Alport's? Or a similar name that sounds like a thing like that?
No, it's not.
Alkaptonuria.
Alkaptonuria.
That starts with Al, too, Mike.
Yes, and yet other than that, nothing like it.
I mean, first two letters. Like, if we're in the dictionary of Durham, those guys are geekers.
Okay. So
multiple choice, unless they put Alport and Alkaptonuria.
Or, like, maybe if everything began with an A. So alkaptonuria.
Like ports.
And so how do the kids present?
Pigment?
Yeah, what's wrong with their diapers?
Dark.
Yeah, they turn black.
Brown.
Diapers that turn black. And then later their elastic tissue turns black, so their ears turn black, their nose turns black, deep where the cartilage is, their intervertebral discs turn black and don't function very well. And so that's all part of the alkaptonuria or ochronosis. And it's deposited, what is that deposited on?
What is the what now?
Those brown bodies, what do they form around?
The dermis, for sure.
What portion of the dermis?
I don't know. I would be guessing.
So anyone? They're elastic fibers. So just as in PXC, it's the elastic fibers that are hit.
So we have some vacuolated cells, some pigment in the dermis, stippling of the granular layer.
So stippling of granular layer, vacuolated cells, a little basket weave, coarse basket weave hyperkeratosis, some round parakeratosis. What conditions give you round parakeratosis?
Epidermolytic. Is this epidermolytic? No.
It's not.
Why do I keep on getting these wrong?
It's a mimic for it. So round parakeratosis, vertical tiers of round parakeratosis you usually associate with anyone? A wart. Yeah. So any kind of wart that would give you blue, foamy,
This is ADV changes.
epidermodysplasia verruciformis. And both of them begin with an E. So it would either be an acceptable choice, because
it was the first two letters.
It was the first.
Which is E. I mean, come on. Epiderma, everything.
So they are epiderma everything, but they're very different syndromes. One of them giving you cancer at a young age. So most of these people die in their 20s or 30s of metastatic squamous carcinoma. Versus EHK, they have very different problems. So important to identify early because the carcinomas, which are very aggressive and metastasizing, only occur where the sun hits. So if there's sun protection, they can do much better. If there's no sun protection, so I think you've seen pictures of the one patient we had who was a redhead with EHK diagnosed in childhood. EDV, epidermal dysplasia versiformis. He went through a rebellious teenage period where he dropped out of school and took a job as a roofer, and had metastatic squamous cell carcinoma then in his young 20s. So round perikeratosis, coarse basket weave-like hyperkeratosis, and blue foamy cells in the granular layer.
I feel like you have focal area that looks PXE-like.
Focal area that looks PXE-like, so calcification, altered elastic fibers in the dermis. Early PXE can look very much like ochronosis. There's a lot of overlap there.
Is this eosinophilic spongiosis with?
There are EOs. I'm not sure there's so much spongiosis as there is a subepidermal bulla.
Subepidermal bulla.
And is the underlying dermis normal or abnormal?
No, it's a busy dermis.
It's a busy dermis. And are the cells black or gray?
Kind of grayish.
And do they overlap or are they evenly spaced?
They're evenly spaced. This masto.
So this is a Derriere sign. This is a scratched mastocytoma that became bullous. Right? That's a Derriere sign. You need to write that on there. Those are all worn off.
Indeed, I did that the other day. It's pretty cool.
That's like a house.
Yeah.
Okay.
So it looks like a compact horn.
Compact horn.
Some pigment down in the dermis.
Some pigment down in the dermis. What do you call that when there's pigment down in the dermis?
Pigment incontinence.
Pigment incontinence. And if you have a little girl and she has streaks all over her body and all you see is pigment incontinence, what might you have named that?
Late stage of IP.
Yeah, incontinentia pigmenti, which is just named for the histologic finding in the late stage, which is pigment incontinence.
So, also there's some dyskeratosis within the epidermis.
So there's dyskeratosis. Is it solitary or a mix of solitary and in whorls and clusters?
Yeah, definitely some whorls and clusters.
Whorls and clusters. And there is glassy expansion of the epidermis, so pseudoepitheliomatous hyperplasia with very glassy cells. So
It's kind of like the middle stage of IP.
So this would be the verrucous phase of IP, which looks absolutely identical to what keratoacanthomas look like when they occur subungual. So subungual KA versus IP, they're dead ringers for one another. They look just the same. And IP, a common late stage lesion as you survive IP, sometimes because of mosaicism. So it's a late hit. So you can have a male with IP who survives because it was a postzygotic hit, and they get late stage lesions. Or you can get girls who survive the early phase and then get late stage lesions, and those tend to be subungual. And they are very painful subungual tumors, and they look just like, clinically and histologically, they look just like subungual keratoid acanthomas. And it's possible that some of what we see as sporadic subungual KAs are actually mutation for IP, for NEMO gene happening, causing these KA-like lesions under the nail. Let's see.
Okay, so there's a lot of hyperkeratosis, and then there is, I guess that's vacuolar change.
And where is it?
Epidermis.
What part of the epidermis?
Granular layer. I would say.
Vacuoles in the granular layer. So let's look at that granular layer. What color are the granules normally?
They're normally kind of a bluish color.
And these have blue and also pink or red. And they're abnormal, and the granular layer is shot full of vacuoles or holes, and you have thick hyperkeratosis. What is this?
I would go with epidermolytic ichthyosis.
Epidermolytic ichthyosis, except the clinical history isn't ichthyosis. Clinical lesion is this was a linear lesion.
So it's a linear lesion.
So now you got a clinician who says, well, I wasn't looking for ichthyosis. This was a linear lesion.
I guess it could be something like Darier's, potentially.
Or it could be a postzygotic mutation of the same gene, right? And it's a linear lesion, so you want to know where is that linear lesion, because now you've got to talk to the clinician about what risk they might have of having a baby who doesn't have a linear lesion but has total body disease.
So it looks like I've got some acantholysis in the epidermis.
Acantholysis, and in fact it's causing a suprabasilar. So a pemphigus-like level split is are your keratinocytes normal?
No, there's some dyskeratosis.
There's dyskeratosis. And
I'm trying to see if I see any correlations.
so not seeing great corons, but there's definitely acantholysis and dyskeratosis and a suprabasilar split with formation of villi. So it falls more likely into the Haley-Haley camp or the Darier's camp.
Haley-Haley? Well, that's not really full thickness. So
yeah,
it would be more
so
Darier's.
this would be more Darier's camp. And often, see these round cells with hypergranulosis and just a little rim of pink around that hypergranulosis?
Yeah.
Those are also corons. They're not far enough along that you see acantholysis, but they're very recognizable. And sometimes all you have is a little collection of those in the corneum. So those all count. Roundish cells, often a blue ring around the nucleus and then a red ring peripheral to that. Looks like another verrucous IP, except this was a lesion from under a nail in an adult. So subungual KA. But look at that. Look at the dermis and tell me, am I a liar or am I not a liar? Is that adult skin or is that kid dermis? That's kid dermis. So of course I'm a liar. That skinny, dark red collagen, so I'm a liar, and this is verrucous IP in a kid.
some EHK.
See some EHK, hyperkeratosis, vacuoles in the granular layer, and big red granules as well as purple granules. So epidermolytic hyperkeratosis.
So there's some acanthosis and acantholysis. It looks more brick wallish than villi and tombstone.
And the color of the rings around the nuclei?
Are red, so I'd be thinking more Haley-Haley.
More Haley-Haley. Okay, very good. We're done.
Yeah,
Shame, though.
okay.
Yeah.